Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out the free resource, the 31-page PDF on the top 200 drugs. It's a great study guide, refresher. I include some of the most important things you're going to see in your pharmacology classes and throughout clinical practice. So again, go check that out. Simply an email will get you access to that for free. And we'll also get you on our newsletter for when we've got new podcasts and other content available. All right, let's get into the drugs of the day today. We've got 81 through 85 of the top 200 medications that I'm going through. And first one is an H2 blocker. So that's a histamine 2 receptor blocker. It is Famotidine. Brand name of this medication is Pepcid. And I certainly do see this medication used in practice. They're kind of a less potent PPI type medication. Mechanistically, how does this work? So famotidine antagonizes histamine 2 receptors, which decreases activity of parietal cells in the stomach. Ultimately, this results in a reduction in hydrogen ions in the stomach, which again, that's the hydrogen ions are the basically basis for getting an acidic environment in the stomach. So if we reduce those, we're going to raise the pH of the stomach and hopefully alleviate some of the symptoms of a high acid environment there. As you could imagine, uses will be similar to that of PPIs like omeprazole, for example. So, heartburn, GI upset, GI ulceration, GI bleed, GERD, those type of indications. So, again, H2 blockers like famotidine, significantly less potent than PPIs. So if we're looking for something to really get after that heartburn or whatever the indication is, most clinicians will typically go to the PPIs first, but an H2 blocker like famotidine is potentially a possibility. So more severe cases of the GI issue, more likely we're probably going to see a PPI. If you got somebody with milder symptoms, that might be a candidate where we start an H2 blocker on an individual there. Dosing can be dosed once or twice daily. I've seen both. One thing that I pay attention to in my geriatric patient population, there has been some reports of cognitive issues or worsening CNS type adverse effects with H2 blockers. I can't say it's something that I've seen commonly, but the one thing I think that I look out for a little bit more so is patients who have declining renal function. So this medication is dose adjusted based upon kidney function. So if you see that diagnosis of CKD, for example, you might want to take a peek and see if we should adjust that dose down for a medication like famotidine. Again, very, very rare, but those CNS type adverse effects have been reported. And again, more specifically in older patients and patients with worsening kidney function. I did want to mention from a drug interaction standpoint, there's kind of some of the similar drug interactions that go along with PPI in regards to reducing the acidity of the stomach. So drugs that require acidic environment for better absorption, iron is kind of a classic example. Using an H2 blocker could potentially reduce the absorption of a medication like iron. There's some antibiotics and other medications too that may be affected by that. I'm not going to go through all those here, but good to remember that if we're changing that pH of the stomach, might not be a bad idea to double check the med list and make sure that we're not altering the absorption of some medications there. I did want to point out a drug in the same class, Famotidine, which I see used occasionally, not terribly often, but Famotidine is in this class of H2 blockers, and it has a tremendous amount of drug interactions, primarily due to CYP3A4. So, again, Famotidine, definitely in my mind is much safer, easier to use when it comes to drug interactions compared to cimetidine, which is also in this class. All right, moving on to number 82, we've got Senna. Sennacides is it may be referred to as well. This medication is a stimulant type laxative. Basically, from a mechanism of action standpoint, it helps the bowel to contract and basically create a bowel movement. Adverse effects with this medication, usually it's pretty well tolerated. We're using it for constipation, so obviously diarrhea could be an adverse effect. I've seen a few cases where patients have been reporting diarrhea, and I look on their medication list and they're taking chronic Senna. So again, just goes to show you, make sure you look at that medication list, make sure your patients understand why they're taking medications. Good, easy situation, easy fix there, where we can simply stop the Senna. I will say one common indication for the use of Senna is with chronic opioid therapy, because opioids are so notorious for causing constipation. We may need a scheduled laxative with that, and I certainly have seen Senna used plenty of times to help with that. With that said, hopefully the opioid is only for short-term use, if possible. It's nice to try to avoid long-term opioid use for obvious reasons and risks. But if we do end up getting rid of that opioid, be sure you look at that medication list. We may be able to get rid of their laxative like Senna as well. That's definitely a point where we can reduce polypharmacy simply if we're paying attention. In comparison to kind of other treatments for constipation, the onset of Senna is a little bit quicker than, kind of your traditional bulk forming laxatives like fiber, for example. So that's kind of a nice advantage to Senna if patients are really struggling and they want something with maybe a little bit quicker onset. That's a potential advantage with Senna compared to maybe some of the other type of agents there. I did skip over one adverse effect. So diarrhea is obviously number one, which is what we're trying to do. We're trying to promote those bowel movements, but because it causes contraction of the bowel, that can be painful for some patients, depending upon kind of their bowel situation and status. So keep that in mind. It may cause some significant abdominal cramping or pain when they take it. So it might be good to kind of warn patients or pay attention to that in patients starting Senna. Drug interaction standpoint, nothing that I really worry about here too much. When I see an order for Senna, I do think about looking at that medication list and saying, okay, what meds is this patient on that's going to cause constipation that's requiring this Senna? Are they taking anticholinergics, opioids I mentioned before as well? Making sure that we look at that med list and make sure we aren't doing more harm than good with the use of medications. All right, moving on, number 83, we've got Novolog. This is insulin aspart. This is a rapid-acting insulin. So recall, rapid-acting insulins are typically going to be used to target those spikes in blood sugar after patients eat. So as you can imagine, we give rapid-acting insulin, just a few minutes prior or right with meals. And again, we're trying to prevent those large spikes in blood sugar following the meal. Insulin aspart can be used in type 1 diabetes, can be used in type 2 diabetes. With that said, in type 2 diabetes, I have certainly seen some basal insulin plus one dose, where we just give one dose of Novolog with the largest meal of the day. So again, kind of can be different variations there, depending upon what's been tried and where they're at with their diabetes care. Sliding scale insulin, I did want to mention this a little bit. So sliding scale is basically treating the number. So for instance, we take a blood sugar, we see that it's 250, and we give X amount of insulin based upon that blood sugar number. So this strategy for managing diabetes, managing blood sugar, is not preferred because we've got that reactive mentality. Okay, so that blood sugar is already spiking and causing damage and problems and concerns. We want to be a little bit more proactive and give that insulin, with that meal that's causing potentially that spike in blood sugar, rather than after the effect. So you don't kind of get this yo-yo effect where it's like, okay, the blood sugar's already spiked, it's already been an issue. Now we're giving the insulin as it's coming down, and now we drop them too low with their blood sugar. So again, that sliding scale insulin based upon the blood sugar reading is not typically the ideal way to manage a patient on a chronic basis. Now, there may be rare instances where kind of the short-term sliding scale may be acceptable. Patients who are very sick, not eating well, hospitalized, those type of patients where a very short-term, sliding scale may be utilized. But again, we really don't want that to be any type of, long-term chronic management with that insulin there. From a drug interaction standpoint, obviously we've got to look out for hypoglycemia. So, adding sulfonylureas on top of this, other diabetes agents, really got to pay close attention for the risk of hypoglycemia. That's one of the biggest risks. Obviously, insulin is a high alert type medication. If we give wrong or incorrect doses, that can be a significant issue. So again, pay close attention. Very high risk medication if you're the one administering this medication. Making sure we get those dosages right, and understanding the ramifications if we're not getting within the appropriate dosage range, the risk for hypoglycemia, and obviously hyperglycemia as well if we're undertreating. All right, let's take a quick break from our sponsor. Are you looking for study materials for pharmacist board certification, like BCPS, NAPLEX, ambulatory care, BCMTMS, or the geriatrics exam? Or maybe you're looking for resources to help you during pharmacology classes in school. Either way, go check out meded101.com/store. We've been putting together study materials and resources for over a decade now, and we try to keep improving them year after year. No nonsense, just important stuff you need to know for exams and clinical practice. Your purchases at meded101.com/store directly support this podcast and helps provide a valuable resource for the next generation of healthcare professionals. All right, moving on, we've got drug number 84, and we've got aspirin. Brand name of this medication is Ecotrin. Most common situation you're going to see aspirin utilized is for cardioprophylaxis. Occasionally, particularly it seems like in some of my older patients, aspirin has been touted as an anti-inflammatory, anti-pain, headache type medication, and it absolutely can be used for that. But it does tend to, cause a little bit higher risk for GI bleed and other issues, particularly if we're using analgesic anti-inflammatory dosages, which are much, much higher, in that 325 to 650 range multiple times per day. So, that's the big challenge with that. Naproxen, ibuprofen, as an anti-inflammatory are typically used much more commonly in practice than aspirin. But obviously aspirin, is one of the go-to, cheap, effective antiplatelet type agents in patients who have a heart attack, for example. You're definitely going to see it utilized in that type of setting, or we're trying to reduce the risk of stroke. Mechanistically, particularly speaking in cardioprophylaxis, aspirin irreversibly inhibits COX-1, which reduces thromboxane A2, and that ultimately leads to platelet inhibition. Okay? So again, not typically used for pain relief, but mechanistically the pain relieving and the antipyretic effects, anti-inflammatory effects are more derived from inhibition of COX-1 and COX-2, more COX-2 for the pain relieving type effects. So COX-1 is more on the side of kind of the antiplatelet type action there. But again, aspirin does both, and particularly at higher dosages, you're going to get more into the pain relief and anti-inflammatory. All right, Reye's syndrome is something I wanted to mention as an adverse effect. This is definitely something that you may see show up on your pharmacology exam or board exam. It can occur with the use of aspirin, but is extremely rare. It's typically only associated with the use of aspirin following or during a viral infection, or at least that risk of Reye's syndrome is significantly increased in that setting, and it's particularly increased in the kids patient population. So the lower dosages used in acute coronary syndrome, cardioprophylaxis, and in older patients, that's unlikely to cause issues with Reye's syndrome. What are some of the symptoms of that Reye's syndrome? So nausea, CNS changes. In very severe cases, seizures, brain and liver damage can happen there as well. Other adverse effects, kind of NSAIDs in general, aspirin kind of included in that category. So GI bleed risk is kind of first and foremost what we worry about with NSAIDs and the use of aspirin. CHF, edema, renal risk, those are all associated with the use of NSAIDs. Again, for cardioprophylaxis, you got an aspirin 81 milligrams a day. I'm typically not worried about those other adverse effects. It's basically just the bleeding risk is what I'm looking out for there. For cardioprophylaxis, so for the majority of situations, 81 milligrams is usually adequate. There may be some, rare situations where we use the higher dose of 325 milligrams once a day in cardioprophylaxis. Usually it's kind of a clinical judgment scenario. So if we know somebody's had a stroke and they've been taking, 81 milligrams of aspirin and they have a stroke on that dose, that's a situation where I've maybe seen, neurology or specialty increase that dose up to 325 in hopes that we're going to get a little added benefit there. But again, as you escalate that dose, you also bring into, you increase the risk for adverse effects, like GI bleed, for example. From a drug interactions standpoint, probably the biggest thing I worry about, particularly with lower dosages, cardioprophylaxis, is just bleed risk. So if you've got patients on other medications that increase bleeding, anticoagulants or other antiplatelet medications, that's probably your most concerning type drug interaction that you're going to want to look out for. So we can certainly monitor, hemoglobin, we can monitor platelets, hematocrit, CBC, things like that. So that can be helpful in kind of keeping tabs on those drug interactions, as well as some of the potential signs and symptoms of anemia or signs and symptoms of easily bruising or bleeding, those type of things as well. All right, last medication for today, number 85, is Baclofen. This is a muscle relaxant. Mechanistically, it's not really well understood how this medication works, but it's suspected to have some blocking action on spinal cord reflexes. I've seen it used, obviously, for muscle spasms and muscle relaxant purposes. From a side effect standpoint, as you could probably anticipate with a lot of medications that are kind of anti-spasmodic, you're going to get some sedation, dizziness, constipation. They can certainly increase fall risk, particularly in older patients, which can be problematic. So pay attention to kind of some of those CNS type adverse effects. I will say with Baclofen, we do have intrathecal administration of Baclofen. So you may see Baclofen pumps out there in practice, and usually this is done by specialties, so neurology or pain clinic or other types of specialties that may work with this a little bit more closely. But maybe you're a nurse, maybe you're a pharmacist dispensing some of this. It's definitely something that you might see given through a Baclofen pump. And one of the reasons for that is we may need that Baclofen at the site of spasticity or the site of action where the problem is occurring. Baclofen does have relatively poor oral bioavailability, and particularly if you're trying to target a specific area, and maybe minimize some of those central nervous system adverse effects, depending upon the situation, that Baclofen may be a reasonable alternative in some cases. With that said, there's not, there's certainly plenty of issues that may be associated with Baclofen pumps, risk for infection and, all the things that go along with that type of administration as well, where it's, maybe a nuisance to do and, all those things as well. So definitely a challenge there. But it is a potential option for some patients that really have a hard time, with spasticity, like patients maybe with multiple sclerosis or other disease syndromes that cause those issues. All right, wrapping up with drug interactions here. The sedative effect is probably the thing I'm most concerned about, and that additive sedative effect. So, taking oral Baclofen with opioids, benzodiazepines, first generation antihistamines, other sleeper type medications, this can have that additive CNS depressant type adverse effect, which can, obviously increase the risk for sedation, confusion, fall risk, and all those negative things. All right, well, that wraps up the podcast for today. Do me a huge favor, leave a rating review on iTunes or wherever you're listening if you found some valuable practice pearls that you pulled out of the podcast today. If you want to reach out to me, mededucation101@gmail.com. Go get your free 31-page PDF on the top 200 drugs. That's at reallifepharmacology.com. And of course, if you're looking for Amazon books, other resources, go check out meded101.com/store. We've got a ton of different resources there that can help you learn pharmacology and become a better healthcare professional. All right, I'm going to sign off for today. Thank you so much for listening. Take care, and I hope you have a great rest of your day.